anemia treated with iron supplement. She has no the history, no the medication. Father has MDD, mother has diabetes and osteoarthritis, and brother has diabetes. On exam, the patient muscle strength is fine. In the and symmetric in the lower extremity. Sensation to light touch is fine. Straight leg, raised stairs is fine. Which of the following is the most appropriate next step?
What is your diagnosis?
The restless leg.
Yes, and in restless leg, we need to exclude the IDA. IDA is one of the risk factor of RLS. So that's why serum ferritin. Do you want me to read the explanation?
Oh, nope.
Okay.
Oh, so iron deficiency is one of the causes of restless leg.
Yes. Iron deficiency, Parkinson may be one of the cause.
Parkinson
Parkinson's
is
disease.
one of the causes. Okay. Okay. Next. 87 women brought to
And the
the
and the treatment of restless leg syndrome.
so give iron or no?
Yes, give iron, and the iron deficiency will correct. But if he has like, if he like for stopping the fighting,
Mm,
previously pramipexole and ropinirole is given, but
mm,
nowadays it is not given. Nowadays alpha 2 delta calcium channel blocker, calcium channel ligand, gabapentin and pregabalin is used. Alpha 2 delta calcium
okay.
channel ligand. Got it?
Wait, so you said that they don't give, because here it says first line, it says that we can still give ropinol. So no?
Usually not preferred. Previously, it is given previously, but now ropinirole is not used. If
Okay.
you go through the box of the RLS,
Mm-hmm.
you will find it. Like dopamine agonist, pramipexole, ropinirole, now it is not preferred. And for iron deficiency anemia, if serum ferritin is less than 75, then supplemental iron should be given.
Just a
And
second. Okay.
the risk factor are iron deficiency, uremia, pregnancy, diabetes, multiple sclerosis, Parkinson's, and even the antidepressant, antipsychotic, and antiemetics. Okay.
You see, if serum ferritin is less than 75?
Yes.
Mm, okay, got it. Okay, next. 87 woman brought to the ED by her daughter because of pain in her hand and wrist after tripping and catching herself with her outstretched right hand. The daughter says that the patient was frail. The daughter says the patient has frail bone and is not taking calcium and vitamin D supplement. Medical history, hypertension, degenerative joint disease. Her only medication is thiazide. She had a tetanus shot 4 days ago, 4 years ago. Vital signs, they are normal. Pulse oximetry is 97. Physical exam shows ecchymosis and abrasion of the right palm. There is swelling and diffuse tenderness on the right wrist. X-ray of the right hand and wrist shows scaphoid fracture. Which of the following is the most likely complication of this patient fracture?
Okay, scaphoid is the carpal bone located at the lateral wrist. It is most common carpal bone to be fractured with the likely mechanism of the injured, the likely mechanism of the injury, and fall onto the outstretched hand. Symptoms of scaphoid fracture include at the wrist, pain at the wrist with possible swelling as seen in this patient on physical examination. Pain can be reproduced with palpation of the scaphoid between the extensor pollicis longus and extensor pollicis longus and extensor pollicis brevis tendon which is commonly referred as the anatomical snub box. The scaphoid is at risk of non-union, and necrosis. Scaphoid is the non-union and necrosis of the proximal pole fracture as the blood supply of the scaphoid arrives distally from the branch of the radial artery. X-ray is the most appropriate imaging in case of unremarkable X-ray finding despite high suspicion of the scaphoid injury. Repeat X-ray 2 to 3 weeks can be performed as the initial imaging will not show the fracture. In such cases, the injury should be primitively immobilized until repeat imaging. And treatment for non-displaced scaphoid fracture is generally non-operative with immobilization. In case of displaced fracture, surgery may be indicated. For this patient, most likely complication of scaphoid fracture is non-union. Um,
E,
Sorry.
can you read E?
Yes, wrist fusion may occur in patients with wrist pain of as a result of non-union or necrosis secondary to scaphoid fracture. Prior to surgical intervention, conservative measures of non-steroidal anti-inflammatory drugs, physical therapy, and corticosteroid injection are often attempted. In this case of scaphoid fracture, the most common complication of scaphoid fracture is non-union. Wrist fusion would be determined following non-invasive attempt at therapy.
Um, hmm.
What are the avascular necrosis? What are the bones causing avascular necrosis?
Mm, the femoral head or something.
Yes,
And,
tell us.
uh,
Is scaphoid bone can cause avascular necrosis?
right? Yeah, right.
Yes, I am thinking
Yeah.
scaphoid,
Fem-
then
It's
the
scaphoid,
femoral.
femoral, and then what else? Which one else?
I don't remember. Like femoral head is one, and lunate fracture can cause avascular necrosis. Okay.
Okay. I think this one with the picture you can get it.
Yes, it's a bullseye rash, Lyme disease.
Right. Right. Okay. Next, or you want me
Next,
to do?
yes, yes,
16 girl comes to the office alone for a physical exam required for participation in athletics. The patient immediately states that the results of her home pregnancy test 2 days ago were positive. Last menstrual period was 2 months ago. She has had mild nausea but no vomiting or fever. Medical history is fine and she takes no medication. Family history is remarkable for congenital heart defect, craniosynostosis, and why is it doing that? And severe cognitive impairment in her brother caused by unbalanced chromosomal rearrangement. Her father is known to be a carrier of a balanced chromosomal translocation and is asymptomatic. The patient lives with her stepmom and biological father, who has full custody. She is at the 50 percentile for height, weight, BMI. Vital signs normal. Physical exam is fine. HCG confirms pregnancy. The patient reports that she does not want to have a child with the same condition as her brother and request genetic testing for herself. It is most appropriate to obtain informed consent for the requested genetic testing in this patient from which of the following individuals? It's
it's
just the patient.
patient. Parental consent is required for most medical care of minors. Exception is medical care related to sexual activity, substance use, and life-threatening psychiatric conditions. Life-threatening psychiatric condition for these sensitive and time-sensitive issues, patient confidently Confidentiality and autonomy are favored over the ethical principle. The patient is required a genetic testing, which is pregnancy related decision. As such, the physician should obtain informed consent from the patient herself. Emancipated minor may also take their own decisions. Okay.
Next. 37 men brought to the ED 45 minutes after the sudden onset of severe sharp pain in his back and chest while he was playing basketball. He rates his pain 8 out of 10. After playing for 2 hours, he had the onset of pain and then had loss of consciousness for 45 seconds. He has Marfan and low standing GERD treated with PPIs. On arrival, he's alert and oriented to he's fine. He is 6 foot tall and BMI is 20. Temperature is fine. It's a bit high. Pulse is high, respiration high, BP low. Exam shows dry mucous membrane. Breath sounds are distant at the left lung base. There is dullness to percussion on the left. Fluid resuscitation is started. Which of the following is the next step in management?
Marfan can cause aortic dissection, aortic root dilatation. So, Marfan fibrillin gene, autosomal dominant. Fibrillin is a component of the connective tissue throughout the body, including the major blood vessel and within the ocular structure, such as jonular fibers. Patients with Marfan syndrome increased risk of vascular complication, aortic root dilatation, aortic aneurysm, aortic dissection, root dilatation, aneurysm, dissection, which may lead to death and early stage aortic dissection presents with severe acute tearing pain, severe acute tearing, chest or abdominal pain radiating to the back, differential pressure between extremities with asymmetric pulses. Dissection begins with disruption of the tunica intima of the blood vessel, which permits blood to dissect the layers of the blood vessel wall with each heartbeat. CT angiography of the chest or CT aortography is used to diagnose the aortic dissection and should be done quickly if the diagnosis is suspected. Okay.
You read F. Where is F? This one.
Placement of tube. Okay, placement of chest tube on the left would be appropriate in the setting of pneumothorax. Patients with tension pneumothorax may present with chest pain and hemodynamic instability, but auscultation of the lungs would disclose absent breath sound and percussion would disclose hyperresonance, not dullness as seen in this patient. These patients' dullness and distant breath sounds are likely caused by the presence of pleural effusion or hemothorax, both of both of which can occur secondary to aortic dissection. Very large pleural effusion may eventually require a chest tube if there is respiratory compromise, but this patient's life-threatening problem is his aortic dissection, and diagnosis can be carried out. Oh, sorry, and diagnosis should not be delayed.
6-year-old boy brought to the physician because of 1 year history of progressive hyperactive and behavior problems. His teacher reports that he frequently disrupts the class. He has asthma treated with albuterol as needed. He occasionally has diffuse headaches. His parents say that he snores loudly, occasionally stops breathing, and moves frequently during the sleep. He plays soccer and baseball. His parents and teachers say he's disobedient. His father has dyslexia, and paternal cousin has autism. Growth and development are appropriate. He breathes through his mouth. Respirations are, I guess, fine. Exam shows moderately enlarged tonsil. He can recall 3 out of 3 objects in 5 minutes. On digit spent testing, he recalls 7 forward and 5 backward. His abstract reasoning is fine. Which of the following is the most appropriate next step?
So he is just hyperactive and
Mm-hmm.
disturbing, like ADHD.
Yeah, I guess. Yeah.
And another thing, like occasionally he snores loudly, occasionally stops breathing, and moves frequently during sleep. So this goes for adenotonsillar hypertrophy, and his tonsil is high. Adenotonsillar hypertrophy can cause OSA, another risk factor. So OSA features uh, repetitive obstruction of the pharyngeal layer during sleep. Typically occurs in patients with obesity because of combination of the structural, vascular, and neurovascular factor. Though older men are most affected, women and a patient who are younger may also be affected. In younger children have a common cause of OSA like adenoid hyperplasia. Patients commonly experience hypoxemia several times nightly and with fragmented sleep and fragmented sleep leading to daytime sleepiness and fatigue. Poor concentration, irritability, and hyperactivity of the children. Snoring related to airway obstruction and is commonly associated with OSA. Diagnosis of OSA is made by polysomnography, and treatment depends on the course, which in this case tonsillar hypertrophy, surgical removal of the tonsil, which is the appropriate option. Okay, can we take a break for 5 minutes?
Yes.
Okay, I'm coming.
Mm, okay. 57 women with metastatic cancer of the sigmoid colon is admitted to the hospital because of 2-day history of progressive swelling and pain in her right arm. The 10 days ago, she underwent partial resection of the liver and placement of a right subclavian venous port. She currently takes no medication. The exam today shows swelling in the right forearm and hand. Okay. Venous Doppler ultrasound shows thrombosis of the right axillary and subclavian veins. The port and catheter are removed, and IV unfractionated heparin therapy is begun. After 2 days of heparin, the patient pain has decreased. Lab studies on admission and after 2 days of heparin are shown. Hemoglobin was low in admission and low after 2 days. Hematocrit 2. Leukocyte count was normal at admission and high after 2 days. Platelet was normal at admission and super low after 2 days. PT, uh, PTT, let me double check, but
Super high.
super
P-
high, right?
PTT is 35 to 45, as far I remember.
Okay, so PTT is high after 2 days after admission, and PT is what? Normal.
PT is normal, almost.
Okay, so PT is normal. I cannot find them here. I don't know why. Oh, right here. Yeah, PT normal, PTT super high. Oh, it was super high at admission. It was high on admission. No, it was normal on admission and high 2 days after. Which of the following is the most likely explanation for the lab findings?
It is heparin causes an immediate anticoagulation through binding and potentiating the action of the antithrombin 3, causing inhibition of thrombin and factor 10A. It is commonly used for anticoagulation. It is commonly used for anticoagulation in the setting of DVT, pulmonary embolism, and acute coronary syndrome. Heparin-induced thrombocytopenia is a potential complication. Heparin-induced thrombocytopenia is a potential complication of heparin therapy. Heat is characterized by thrombocytopenia that typically occurs 5 to 10 days following heparin exposure, along with the evidence of arterial and venous thrombosis. Complications include organ ischemia, skin necrosis, limb gangrene. Heat occurs secondary to production of IgG antibodies against the complex of heparin and platelet factor 4. This leads to activation of the platelets, which can cause thrombosis and consumption of the platelets. This abnormal activation this abnormal activation yields progressively decreasing platelet counts, at which typically nadir at greater than 50% of their initial level. Onset can occur sooner after exposure to heparin, as seen in this patient, due to an anamnestic antibody response driving early antibody production. Treatment requires cessation of all heparin-related products, unfractionized heparin, low molecular weight heparin, and the initiation of direct thrombin inhibitor or direct 10A inhibitor anticoagulation without worsening the thrombocytopenia. Okay.
What is some whatever that word? Anam
Anamnestic
mean?
antibody response.
What does that mean?
I completely forgot. I read about that, but I forgot. You can Google it. I'm seeing.
Okay. Anamnestic antibody response. Okay, I'll Google it. Anamnestic antibody response. It. An anamnestic is immune response is not observed upon exposure to heparin, even months or years after the initial episode. This means that patients who have developed heat antibodies do not experience rapid or and strong antibody regeneration upon subsequent heparin exposure. What that means? I'm like so confused with what they're saying. Okay, so
Uh,
okay,
Anamnestic, like in delayed hemolytic transfusion reaction. Uh, Wait,
oh,
you got
okay,
the point.
okay,
Second, like
okay.
secondary immune response.
Okay. So they said that why he was exposed to heparin, that she was exposed to heparin before and had heat, and she had heat, so now she's exposed again, and the heat is happening faster. That's what they're trying to say, or
like
not?
like creating the memory cell inside them, and then the responding faster. This uh
Mm-hmm. Okay, okay. Because here it says, you see, it says typically heat occurs like 5 to 10 days following heparin exposure, but in this patient, it occurred 2 days
okay,
following the
yes,
heparin exposure. Okay, so she already had memory, like I guess
memories,
antibodies before.
yes, memory
Okay,
cell.
okay, okay, okay. Got it, got it. Okay, okay. Next. 42 men comes to the physician 12 hours after the onset of increasing mild epigastric pain and decreased appetite. 12 hours. He has not eaten during this period. He has vomited greenish material 10 times during the past 4 hours. He has not had fever or chill. He was treated for malaria 25 years ago. He currently doesn't take medications. He immigrated to the US from Ghana 20 years ago. No smoking, no alcohol. He appears ill and is in mild distress. Temperature is high, pulse is high, respiration normal, BP low. Exam shows dry mucous membrane. Cardiopulmonary exam is fine. Abdomen is soft with mild epigastric tenderness. There is no hepatosplenomegaly. Bowel sounds are high pitched. 3 centimeters tender mass is palpated in the right groin. Test of stool for a cord blood is negative. Labs hematocrit is, I believe, is high, but let me double check. Sodium is low, potassium is normal, chloride is low, bicarb is high, urea is high. Yeah, glucose is, I believe that's normal. What is normal? Or is it high? No, it's high. And creatinine is normal. Platelet, I believe, is normal. Let me see, leukocyte and hematocrit is normal. Leukocyte count is normal. Where is the leukocyte? Did I miss it? Over here. It's high. Neutrophil segmented is high. Lymphocyte is normal. And monocyte normal. Abdominal X-rays are shown in addition to placement of a nasogastric probe. Which of the following is the most appropriate next step? What do you see in the this one
Like
in the
bowel obstruction, small bowel obstruction.
right?
Yes,
Mm,
in the air fluid level on the X-ray, we found in the like air fluid level on the plain X-ray, dilated
mm,
loops of small bowel with air fluid level. And another thing, in a small bowel obstruction, there may be bowel sound is high pitch, like
mhm.
hyperactive to absent bowel sound. That is the way. Like abdomen,
Hyperactive what? Say it again.
initially hyperactive, then after this hyperactiveness, then absent bowel sound.
Absent bowel sound.
Like bowel try to save themselves and starts activating hyperactively, then they get fatigued, like that, like hyperactive to absent bowel sound. And there may be abdominal pain, abdominal distension, obstipation.
Mm-hmm.
Okay, so we have given bowel rest, nasogastric tube suction, and IV fluid, isn't it? The next thing is surgery. Even if the patient is not that hemodynamically stable or unstable, like blood pressure is not that very low, but the next step is the surgery. Okay, obstruction of the small bowel occurs partial or complete of the small bowel lumen, typically presents as nausea, bilious, vomiting, abdominal pain. Small bowel obstruction is most commonly caused by peritoneal adhesion that form following previous intra-abdominal surgery or hernias. In inguinal hernias are protrusion of abdominal content into the inguinal region through the defect in the lower abdominal wall. Incarceration and strangulation are potential complication in the inguinal hernia. This patient likely has incarcerated inguinal hernia, which presents as tender mass in the inguinal canal, leading to small bowel obstruction. On physical examination, patients typically present with abdominal tenderness, distension, tympanic to percussion, borborygmy, high-pitched hyperactive bowel sound. High-pitched hyperactive bowel sound. Abdominal X-ray typically show multiple air fluid level in the setting of dilated small bowel loops, such as this patient. Management require bowel rest and IV hydration followed by surgical intervention of the incarcerated or strangulated hernia. Okay.
Okay. 37-year-old woman, gravida one para one, comes to the physician for postpartum examination 6 weeks after spontaneous vaginal delivery. of a 7 pound newborn. Delivery was complicated by vaginal laceration, which was repaired. She stated that she has had occasional fecal incontinence and flatus since delivery. She has not had urine incontinence, fever, diarrhea, constipation, or pelvic pain. She has Crohn's disease treated with prednisone. Her last flare-up of symptoms was 6 months before delivery. Her temperature is fine. Physical exam shows that the sutures in the vaginal mucosa are healing well. There is a 3 centimeter defect in the rectal mucosa with communication with vagina. The anal sphincter is partially torn. Without treatment, which of the following is the most likely outcome?
This postpartum patient on chronic corticosteroid with the recent 4 degree of laceration extending through the anal sphincter. It is extending through the anal sphincter, persistent rectovaginal fistula, and partially torn anal sphincter is most likely have persistence of rectovaginal fistula if she is not treated appropriately. The rectovaginal fistula is formed between the rectum and the vagina, which most commonly presents with foul-smelling vaginal discharge, dyspareunia, the passage of gas or stool. The passage of gas or stool from the vagina, vaginal irritation, and a tendency for urinary tract infection. It occurs most commonly as a complication of childbirth, but can occur due to other sources of pelvic trauma, surgery, radiation therapy, chronic inflammation. In relation to childbirth, it can occur secondary to prolonged labor, consequent pressure necrosis, or surgery to a failure to recognize or appropriately repair a or fourth-degree vaginal laceration. The latter, which is most commonly cause for this patient's rectovaginal fistula. The patient has increased risk of rectovaginal fistula formation and the persistent as a result of chronic inflammatory state secondary to Crohn's disease and our use of corticosteroid which impair the proper healing process. Treatment of rectovaginal fistula is operative repair.
You read A, B, this one. A.
Yes, complete closure of the defect or partial closure of the defect is unlikely. This patient has this patient had a severe perineal laceration during delivery. Severe perineal laceration during delivery that was unrecognized or inappropriately repaired, which lead to presence of our rectovaginal fistula in the setting of severe injury, as well as her inflammatory bowel disease and chronic corticosteroid disease. She is likely to heal to have either partial or complete closure of the defect. Okay.
A 12-year-old brought to the ED 15 minutes after his parents found him restless and confused in the basement. He also had slurred speech. He has no history of serious illness, doesn't take medication. While waiting to be examined, he falls asleep but is easily arousable. Physical exam shows nystagmus, muscle strength is 4 out of 5 everywhere. Mental status exam, he's oriented to person and place but not to time. He reports no hallucination. There is no evidence of delusion. Urine toxicology screening is negative. Use of which of the following substance is most likely the cause of the patient condition.
Inhalant use disorder like blue shoe polish told with nitric oxide is common in children or adolescent as affects multiple organ system. dermatological perioral or perinasal dermatitis with pyoderma, otolaryngology, conjunctival injection, nosebleed, unusual breath odor, gastrointestinal unusual breath odor, gastrointestinal nausea or anorexia, respiratory wheezing, coughing, sneezing, and neuropsychiatry, especially hydrocarbons, glue pains can produce neurologic effects, including slur speech, ataxia, nystagmus, disorientation, hallucination, and central nervous system depression, alternating with restlessness and agitation. The effects typically begin with seconds of the use, persist for approximately 30 minutes, representing a faster onset and resolution compared to another recreational drug. When inhaled chronically, toluene containing glues can lead to hypokalemia, generalized weakness, paint or glitter may be seen on the patient's face and hands. Notably, inhalants are not detectable on the standard urine or toxicology screening. So, how it can be detected? Treatment is primarily supportive, though inhalants have positive antidote, methylene blue for nitrate. Prevention is the key. Schools should monitor use of solvent-based product, and patients and children should be educated about the risk of inhalant intoxication. Can you tell me how you diagnose this as inhalant?
Oh, shoot. I don't think.
Because
I don't.
inhalant is not common,
Yeah, it's not. I think
and
I just. Uh huh.
and I don't know how to diagnose this inhalant.
I think I just removed the other ones. Like I knew amphetamine will show on the urine toxicology, and
Yes,
then I think and cannabis also would show on the recording, like cannabis, marijuana, all these things will show. I think, yeah. And then the cough suppressant and the opioid, they kind of cause the CNS depressant effect. Like the opioid and the benzos and all that, the CNS depressant effect. So, but here it says that he is restless and confused, so he's moving a lot. So he's not like, you see what I'm saying? Say.
okay,
Um, yeah, I think that's how, and he has nystagmus, and I don't think opioid. I don't think opioid has any kind of nystagmus thing. So that's kind of. I think I just deleted the other ones and just came up with that, but I'm not sure.
okay.
Can you read B and E?
Yes,
Mhm.
cough suppressant medications that are commonly used. A cough suppressant medication that are most commonly used recreationally may include dexmethorphan and NMDA receptor antagonist and SS serotonin receptor agonist or codeine opiate receptor agonist. Because codeine is CNS depressant, restlessness, generalized muscle weakness would be uncommon. Although codeine is detectable on standard urine toxicology screen, like other NMDA antagonists, dexmethorphan may cause hallucinations, agitations, nystagmus. Sedation would be uncommon. And next,
E.
and synthetic cannabinoid is a hallucinogen that causes euphoria, paranoia, hallucinations, cognitive slowing, conjunctival injection, dilated pupil, nystagmus, sometimes occurs. This patient has nystagmus too. Synthetic cannabinoids are more potent than cannabis that are most likely to cause psychotic symptoms, hallucination, paranoia, which this patient does not demonstrate. Physical examination does not show conjunctival injection or dilated pupil. Mm, which would be present with synthetic cannabinoids. Unlike cannabis, synthetic cannabinoids is typically not detectable on standard urine toxicology screen. Generalized muscle weakness, generalized muscle weakness and severe cognitive effects, disorientation, confusion are common. Okay.
Okay, so cannabis will cause red eye, which the patient doesn't have. Okay,
Yes, you can see the question ID 18320.
let me see.
Okay,
11832
you can
0.
search and you can see now.
Okay. Wait, you want me to do it now?
You can see there it is similar to this. That's
To
why I
this
told
one.
you.
Okay. Okay. Wait, you
I-
want me to look at it now or later?
If you have opened the first aid, then you can put the ID. Then
You
you
mean the
can,
URL?
yes, in the URL.
Okay. Create test. Okay, I do custom.
No, you not don't need to do. Okay, 18320. Only one question.
So here, right?
Yes.
Okay. 183.
You can search it on the search button also. Like you do not need to.
Oh.
You do, yes, in here.
18320. I didn't know.
Then you don't need to do the
Create a block. That makes more sense.
yes. Okay, look at
Okay.
this question. Okay, I'm reading the question now.
Mm-hmm.
A 13-year-old girl is brought to the office. 13-year-old girl is brought to the office by her mother due to abdominal pain. The mother says she has had occasional stomach ache for the last few weeks. Stomach ache. I thought it was just menstrual cramp, but she has started skipping meals and looks like she's losing weight. Her mother also reports that the patient has become increasingly irritable, locking herself in the bedroom. You cannot highlight now.
Oh. Okay.
Okay, locking herself in the bedroom and coming out to watch television. The patient says that her mother is freaking out about nothing and that she feels fine. She has no nausea, vomiting, and change in the bowel habit. Medical history is significant for seasonal allergies treated with loratadine. Vital signs are within normal limits. A 5 kg weight loss, okay, for 6 months. Physical examination is significant for a flaky eczematous rash around the mouth involving the nasolabial fold. Flaky eczematous rash around the mouth involving the nasolabial fold. Uh, Abdomen is soft and flat, no tenderness to palpation. A bilateral hand tremor is noted, and further neurologic examination shows globally decreased reflexes. Which of the following is most likely diagnosis?
Mm. Yeah, I will not have gotten this question right.
Sorry.
I will not have gotten this question right.
In
Because
in this question there is some clue, but on that question I haven't found any clue.
yeah,
Like
on this one, on
in this one,
uh
I'm reading the explanation, then you will get the clues. Like
Mm-hmm.
initially it looks like acute intermittent porphyria, like
Mm-hmm.
abdominal pain. There is uh, other feature initially I thought, but look, okay, this patient's irritability, abdominal cramp, anorexia, irritability, abdominal cramp, and anorexia in combination with perioral dermatitis and neurologic sign concerning for inhalant use or intoxication. So inhalant use are easily accessible, found in everybody products like glue, shoe polish, gasoline, spray, paint. They spray paint, they readily cross the blood-brain barrier. They readily cross the blood-brain barrier, resulting in euphoria and intoxication. A use typically begins in childhood or in the early adulthood via sniffing or inhaling, placing a rag soaked with the substance on the mouth or nose. The key here is perioral dermatitis, like glue sniffer's rash. Those who smell the glue is due to drying effect of the hydrocarbon. It extends around the mouth or nose, involving the nasolabial fold, a highly characteristic feature. Other clues of inhalant use is the odor of the chemical on the breath or cloth, or finding rag or gauze or chemical containers on the trash. As acute symptoms like neurologic tremor, disorientation, headache, slur, speech hallucination, gastrointestinal, cardiovascular symptoms, and there may be psychiatric symptoms, irritability, mood swing, and these and that, anorexia, cerebellar dysfunction can happen, peripheral neuropathy. Okay, this patient has peripheral neuropathy also, like decreased reflexes. So got my point. But
Mm-hmm.
look, in AIP, there is abdominal pain, like personality change and peripheral neuropathy. But however, it tends to manifest between 20 to 40 and does not cause this one, perioral dermatitis. So,
Okay.
but on that question, I don't found any clue.
Mm. On this one actually for me was is more difficult than the other one, than the one that we saw here.
This one is easier for you, like in NBME one.
In the NBME, yeah.
Why? What are the clues you have found?
I don't know. I think I can just delete the other ones because of the urine toxicology one. I can eliminate the amphetamine and the cannabis,
Yeah,
and
okay.
then yeah, and then because
Cough
he
suppressant, like cough suppressant, it is not found on the urine, is it?
yeah, no, I don't think so. But the cough suppressant kind of acts. I don't know. In my head, I feel like it kind of
Cough
acts like
suppressant also found in the urine. Codeine is detectable on
oh,
standard. Okay.
cough suppressant. Well, okay, I guess. But it also will cause. It's like a CNS depressant. But this girl is like restless, so she's moving a lot. So she's not like like benzos, like calm and all that. So I will. I mean, I don't know. I feel like this one is a little bit, but I guess yeah, yeah. Here the key is the perioral dermatitis that they didn't give on the MBME. Yeah,
In
yeah.
NBME, they put this question in different direction.
Mhm. Mhm.
Still, I do not like, apart from excluding the answer, I do not found any
Yeah.
specific clue that
No.
that is it.
Yeah. No.
Okay.
Mm. Okay. That's a good question, though. Okay, next. Oh, 24, no, 27 men comes to the physician because of a painful lesion on his left palm that has been enlarging during the past 9 months. 2 years ago, he underwent cauterization with liquid nitrogen for a wart-like lesion at the same site. The lesion decreased in size but never completely resolved. Since the procedure, he has had episodes of skin breakdown with clear malodorous drainage. He is unable to grip objects with his left hand because of the pain. Temperature is fine. Exam of the left hand shows 4 times 3. centimeter red irregular shaped lesions overlying the hypothenar eminence that rise 1 centimeter above the skin and is fixed to underlying tissue. The center of the lesion is necrotic with a serosanguinous malodorous discharge. Sensation to pinprint is decreased over the palmar surface of the left small fingertip. The remainder of the exam is fine. X-ray of the left hand shows no abnormality. MRI of the hand shows large, irregularly shaped marks extending from the skin of the hypothenar eminence into the Guyon canal and the carpal tunnel. Results of an open biopsy of the lesion shows high-grade epithelioid sarcoma. Staging CT scan shows no evidence of it. Which of the following is the most appropriate next step? Oh,
Very boring question. This one. So, amputation is the because there is no metastasis. There is no metastasis. So, amputation may be the answer for epithelioid sarcoma. Epithelioid sarcoma is a rare soft tissue tumor that is clinically presents as slow growing firm subcutaneous nodule, slow growing firm subcutaneous nodule of the distal extremities, often involving hands and digits. Peak incidence of epithelioid sarcoma in between age 20 to 30, in patient age 20 to 40 years of old, and has been associated with Lee-Frommany syndrome. Epithelioid sarcoma associated with mutation in the chromosome 22q11 region, which contains IN1 tumor suppressive gene. Diagnosis of epithelioid sarcoma is based on characteristics biopsy finding. Histologically, like dermatofibrosarcoma protuberans, tumor show CD34 positivity. Epithelioid sarcoma may be subclinically spread along the deeper anatomical structure, including tendon, nerve, fascia, due to high likelihood of the spread. Aggressive surgical therapy with amputation is recommended. Postoperative radiation therapy may be benefit with large tumor. Okay.
can you read all the other answer
Yes,
choices?
yes. Okay. Do you remember the complication of the amputation, like neuroma, phantom
Oh
limb
yeah.
pain?
Mm-hmm.
Can you tell me the difference? How we can differentiate?
Oh, I cannot tell you now.
Okay.
I did not.
These days I am thinking a lot. That's why I'm asking.
I just know the phantom limb is the one where you feel it on the limb that was taken off. You
Yes,
feel, yeah,
that
that was
portion I got. Like
yeah.
when in the stem, mm, it is tough to differentiate. When we read the stem, I feel hard to differentiate. Okay. Like there is a presence of
Mhm.
pain over the stump, that part. Okay. Chemotherapy is often employed as an adjuvant therapy for cutaneous and soft tissue tumors. Chemotherapeutic agents are most effective against fast growing cells. However, they are less reliable in slow growing tumor, such as epithelioid sarcoma. For this patient, amputation is the most appropriate next step. Radiation may be used as an adjunct therapy following amputation for the treatment of epithelioid sarcoma. Radiation therapy causes DNA strand breaks in the rapidly growing and dividing cell. External beam radiation may be used to target tumors at a specific depth below the skin, while radiation may be used as an adjunctive therapy, and it is not a first line therapy for the treatment of epithelial sarcoma. Split thickness skin graft may be used to provide wound closure of the dermis and a portion of the underlying dermis in areas of trauma for burns, chronic wounds, and large surgical defects. Split thickness skin grafts are commonly used for larger defects and have a lower metabolic demand than full thickness skin graft, but have worse cosmetic outcomes than full thickness grafts. Split thickness skin graft may be used to close surgical defects following amputation for epithelial sarcoma. Full thickness graft may be used to provide wound closure of the epidermis, the entire dermis, in an areas of trauma for burns, chronic wounds, or large surgical defects. Full thickness skin grafts are used for closure of smaller wounds and have higher metabolic demand than split thickness graft have improved cosmetic outcome. Okay, I don't know what I am reading actually.
That's what I told you to read because I was like, wait, I don't understand this.
I am reading like an essay. Okay, we can stop because I think that
Yes,
my
yes,
brain is not working.
yes. Let's stop
And
here.
this is a very boring question. Why this type of boring question is given?
Okay.
Okay,
Okay. I'll see you tomorrow.
okay, bye bye.
Bye bye.